Welcome to our sixth Agile seminar on attendance. That's hard to say. I'm delighted today to be joined by Russell Viner, Chief Scientific Advisor to the Department for Education, and Peter Fonagy, OBE, National Clinical Advisor on Children's Mental Health, NHS England. Russell and Peter are both members of the Attendance Action Alliance, which is a group of national leaders who've been convened with the single aim of raising attendance in schools across the country. They bring their deep scientific expertise to bear in understanding the psychology of belonging and the relationship between mental health and absence. So we're very lucky to have them today. Russell and Peter, thank you. Over to you, Russell.
Thank you, Samira, and good morning, everyone. Thank you for the introduction. So I've been the DfE's Chief Scientific Advisor, or CSA, for about a year now. So my background is I'm a paediatrician. I still see young people, particularly teenagers, every week in clinic. And I've done quite a bit of research over time, particularly in the public health and policy space, on the links between health and education. And that crosses both physical health, but also mental health. But I'm not here to talk particularly about that today. Just to say, you probably don't know what a CSA, or a Chief Scientific Advisor, is. So I'm an independent scientist that's seconded into government. So I work for the DfE 3 days a week. My job is to provide science advice to ministers and senior civil servants. I'm not a policymaker. I don't set DfE policy, and I can't speak for the DfE in a direct sense. So just to be clear about that, my job is to make sure that ministers and the top of the DfE, well, all bits of the DfE, have the best advice when they make decisions. But if you remember from the pandemic, the mantra is that scientists advise, but politicians decide. And they decide based on a range of different things, of which science is only one. So on that, given that caveat, though, I think ministers and civil servants and perhaps everyone is really interested in understanding more, particularly about the association between mental health and absence. I don't need to repeat the statistics on absence. You will all, those of you who work in schools, will see this absolutely every day and will know it much better than I hear about it from my patients that I see each week in clinic, but I don't live and breathe it as you do. So talking about mental health and absence, we often see this in different ways. During the pandemic, we were, of course, really interested in what would be the outcomes of that long absence that our children and young people had from schools. The real concern about the long shadow of the pandemic. And in that case, we were very clearly thinking about the link between absence leading to mental health problems. In fact, I'm just going to put my slides up, not that they particularly illustrated about this, but I might have to put them up at some stage. So I will do that. I'll share that and then put them on slideshow. Has that gone onto the slideshow? I think it has. You can see the slideshow? Okay. So very simply, just trying to make the point, I think, that mental health and absence are linked to each other in two ways. They're in a sense mutually reinforcing. So during the pandemic, just to repeat, we really worried about absence leading to mental health problems. And I think we're very clear that that occurred, and that part of the rise in children and young people's mental health problems during the pandemic and afterwards, and there's a bit of debate about that, but was related to not being in schools, the lack of sociability, the social isolation, all those things that schools bring. So that's a very important link. But there are questions about whether that's really causal, whether actually the absence causes the mental health, or there's a range of other things going on, because we know that both of these mental health problems and absence are actually strongly linked with things like deprivation, family issues, so both family culture, parental issues, parental mental health, stress at home, domestic violence. All of these things can be both linked with more mental health problems in a child or young person and absence. So it's actually really difficult to prove that the arrow goes from absence to mental health, even though it seems obvious. And then at the moment, real concern about absence itself, with these very high levels of persistent absence and general absence post-pandemic. And a suspicion by many that and a suspicion, and I expect those of you in schools are told this by parents, by young people, are told that some of the cause of this absence is due to concerns around anxiety or around a range of other mental health problems in schools. So the suggestion that the arrow goes from mental health to absence. And again, it's been difficult to prove that. I mentioned deprivation. I mentioned problems in the family. There's a whole range of other factors that I probably don't need to go into today that could underpin either of these arrows. So we're left with a bit of a morass, actually, in an academic sense. And by the way, I should say, I'm going to be talking more about some of the concepts and showing you some data. And Peter is going to follow up and actually talk about what to do about this. So a bit of a morass, and could be a bit difficult to really establish truly what causes what. Now, you might say, is that important? Let's just get on and fix it. But my job is as Chief Scientific Advisor, of course, to make sure that we do things that are properly evidenced. There are many things in politics and policy and in health, where I come from, that we can do that seem the right thing to do, but actually, when we look at them properly, we realize there isn't the evidence for them, or they particularly could be harmful. So we absolutely have to understand the true associations so we can be most effective when we act and make sure we don't cause harm. So both of those are really very important. So just moving on, just trying to look. So this is some data from before the pandemic, from a very, very large national survey, a Millennium Cohort survey. So about the best data we have. And this tries to look at both of these associations. So we're trying to look at mental health leading to absence. So these graphs show mental health at 7 years. So higher absence in the orange on the left-hand graph in those with mental health problems, and much, much lower absence in those with normal mental health or without mental health problems. And if we look at those with mental health at 7 years, we can see they continue, regardless of what happens later, they continue to have higher absence at 9 to 10, 12 to 13, 13 to 14. And if we had the data, I'm sure we would see it later on. And the same thing's true if you actually look at mental health problems at 11 years, the start of high school, and then later. So we see that it appears there's a strong link, but this is just raw data. We need to be thinking about some of those other problems. If you look at it the other way around and you say, let's start with absence and look at mental health problems later, and if you just look at what happens at, say, 7, 11, and 14, which is when they collected data in this great survey, again, we see very, very clear evidence of the same thing. Sorry, the orange has dropped off the left-hand graph, but essentially the level of persistent absence is in the orange. And you can see those with mental health problems have much higher persistent absence at 7. So those with persistent absence have much higher mental health problems at 7, but continue to have mental health problems right through the later years. So these things seem to track. Now, so I'm going to show you a careful model. So, but this is really difficult because we know that if a child starts coming to school at 4 or 5 and gets difficulty with separation or attachment and has difficulty staying in school, that actually that itself may track, but it also may snowball. So if you want to look at associations between absence and later mental health, you have to take account of them at each stage. And you also have to take account of what we call baseline issues, what we call confounders in science. So things like deprivation, we know is a potential confounder. You could hypothesize that different cultural backgrounds might be confounding of this. By confounding, we mean things that might show what appears to be an association that aren't. And essentially for all of these analyses, we would always adjust for sex and ethnicity anyway. But then we would think about what we call time varying confounders, because it may be if you're looking at the association between absence and mental health in high school, you need to be both thinking about what happened right at the beginning of school. You need to be thinking about parental mental health, not just in high school, but actually what's happened over time, how well they did in school previously, because of course, if you are not doing well at school, it can be a driver for you to attend less. So there's a whole range of things, obviously special educational needs, bullying, etc., etc. So we undertook what was really quite a complex model to try and really tease out the true causal link between absence and later mental health, taking account of all of the earlier associations of these things and all of the other things that we could think of that might bias this association. So sorry about all the arrows. This is basically trying to show you how clever we were and how clever this analysis is. So sorry about the boasting. It's only there to show you we try and thought about this very carefully. So what did we find? So for the issue of absence leading to mental health problems, we found that if you are persistently absent at any time from the beginning of school to later, you approximately doubled the risk of mental health problems. And that was true at that sort of school entry age. It was true in that sort of later primary school age, and it was true in the early secondary school age. And we didn't have the data to look in later secondary school. And this was true when one took account of all of the associations at each time. So we think that that's a causal association, that being absent from school is actually bad for your mental health. And that's a very strong rationale, apart from the fact that it's bad for your later life chances in many ways. But this is the strongest, most causal evidence we have. Okay, what about going the other way? Sorry, I seem to jump on. If we do the same thing and the same analysis, I won't show you all the arrows and all the blobs, but essentially we kind of reversed the analysis. We looked at mental health problems leading to later absence, and we accounted for those baseline things such as deprivation, and we accounted for things that varied over a child's life, such as maternal mental health problems, such as diagnosis of SEND, etc., etc. And we actually found a very similar doubling. So mental health problems at school entry doubled risk of mental health problems at school entry doubled absence a few years later, and again, all the way through school life. So we're very confident that these associations are causal. And you might think I'm belaboring this point, but we should not be acting on this until we are secure and know that this is causal. So this is important. We also, and as I said, I'm a pediatrician. I particularly treat children and young people with type 1 diabetes each week in clinic. We know that there are many other medical reasons that lead to absence, but mental health, of course, is the one we're concerned about today. I hope that's very helpful. I hope that's vaguely helpful. I'm going to hand over to Peter, and I think we're going to do questions all together after that.
Okay, let me now do the most difficult part of my presentation, which is sharing the screen, but just to introduce myself, as Russell has done, in what I think you have to appreciate is an extraordinarily compelling demonstration of the importance of attendance. And this is really, right now, scientifically at the cutting edge. Most of the other studies show correlations. This is the best control data that exists out there for this country, certainly. And I think we're very privileged to have this analysis presented to us. Okay, so I'm going to be talking about the interventions and the literature on the interventions and maybe make some comments around it. In questions, I'm very happy to elaborate on anything I've said. If any of you would like to use any of these slides, there is my email. Just pop me an email. I'll send you the slides. Not a problem whatsoever. Very quick to do. Happy to do it. So, what do psychological intervention do to increase school attendance? Well, there is a large review, a meta-analysis of 8 reasonably well-conducted randomized controlled trials and quasi-experimental studies that summarizes the data. 7 of these looked at cognitive behavior therapy. 1 tested group counseling. And it does appear to be the case that attendance is increased by about half a standard deviation, which is an important amount. It's no panacea, but it does seem to do quite a bit in improving children's attendance. One important result from this meta-analysis is the recognition that actually what we are treating is not necessarily the anxiety. When we get children back to school using cognitive behavior therapy or other methods, we actually increase their confidence, their self-efficacy, rather than reducing their anxiety. So the anxiety is a pretty pernicious problem and probably needs to be addressed separately. But at the same time, I think it's important to say, just one example program, one published, it's not part of this meta-analysis, published a couple of years ago, that shows that a manual that's a cognitive behavior therapy manual used alongside a specific intervention aimed at increasing attendance, and I'll say a bit more about what these interventions are, is acceptable, that 92% of adolescents complete the program and are available for follow-up at 12 months, that the impact of this combined intervention is large in terms of more than a whole standard deviation, 1.13 standard deviation in terms of a change, that depression is reduced and anxiety symptoms are reduced. And this is if you do address these, address anxiety and depression alongside school attendance. But also that there is this impact on confidence, on self-efficacy. Children, young people feel better about what they are able to achieve. And the size of the increases are really quite marked. What you see in the pale blue is the children who can attend fully, are no longer persistent and attendant. And you can see that at 12 months follow-up, the effect is maintained and the effects are strong. So I would say that we do have interventions that help. What factors influence the outcome of these interventions? Well, I think one has to say from studies that are largely qualitative, but actually have consistent findings across many, many cohorts, that there are many reasons for non-attendance. The experiences, however, that children have following persistent non-attendance are very similar. So what are the reasons? It could be things like making friends, not being able to make friends, not feeling that they can fit in, feeling uncomfortable during specific subjects, feeling bullied, being bullied. The schoolwork or their lessons feel confusing. They feel pressured to learn in certain ways. They feel they need to find links to a teacher who they find difficult to make links with. They may be worried when they arrive at school by the school environment. They may experience the school environment as noisy or overwhelming. The difficult experiences may be outside of school, bereavement, illness. For some children, the school environment just doesn't feel right. Children with special educational needs in particular, autism, ADHD, dyslexia, they may have persistent physical problems like Russell was mentioning. Whatever the route, though, when they present with the problems, any intervention appears to be delayed. It starts several months after the young person has stopped attending school. And you heard Russell say how non-attendance causes mental health problems and mental health problems causes non-attendance. Now, if you put these two into a loop, into a vicious cycle, that delayed intervention inevitably causes, you're building yourself a substantial difficulty for that child. Families, children, young people experience the support as absent, inflexible. For example, timetabling is not modified for them. Families, children, young people feel blamed for not attending, for the difficulties that they are experiencing, and people not taking their difficulties seriously. So the general features of interventions that work have components that address these issues. So the first and most important component is to build partnerships between school staff, parents, mental health services, and the range of professionals that are likely to be involved in their child's life. Working on an individual level is important because each case is different, as I tried to say. The causes are specific. And if you are trying to apply a one-size-fits-all solution, you're likely to fail. So interventions that go to the families and try and help them identify the specific problems and then negotiate difficulties in relation to all the other agencies that are involved, including education, are the ones that are likely to be most effective. Ultimately, children need to be supported to feel safe enough to go to school. Not necessarily their anxiety dealt with, although that helps, but actually just to feel safe enough. A crucial part of this is listening to the child, listening to the young person, and create an environment to support their academic progress and create opportunities for them that actually ends this vicious cycle and creates protective issues. So, what has NHS done to increase resources to intervene in schools? Well, we have revised the training programs that we offer to educational mental health practitioners, or EMHPs, who work in schools, have worked in schools since the Green Paper of 2017, implemented in 2019. So in senior wellbeing practitioner training, we have devised a special module in relation to school-related anxieties that help educational mental health practitioners learn how to intervene with these anxiety presentations, intervening with social anxiety, separation anxiety, other things that can individually cause these problems. We have also strengthened our module on autism that can be vital in some cases. Low intensity behavioral approaches to anxiety work for individuals with a diagnosis of autism, for autistic children and young people, but they have to be modified to be effective. We're also able to offer group-based parent-carer training programs that leads to better insight and behavioral management strategies for children and young people with this diagnosis. We've also modified the basic education mental health practitioner curriculum on management of background anxiety related, for example, to bullying, exam performance, can, as I said, be critical issues. And most importantly, we're trying to work, and that's hard, I can assure you, to make our educational mental health practitioners work with schools in a holistic way, engaging everyone in the school in order to be able to offer the school more support, to give more support to the children. And I'll say more about that in a minute. It means involving senior colleagues in the educational system, influencing the culture and the organization of the school. Just rather in a boring way to say, because I'm involved with the NHS, I have to boast on our behalf. We have now trained 2,500 educational mental health practitioners. There are over 500 of them currently in training, but not all of these will do the senior mental health training. What we can, I think, guarantee is that in mental health support teams, which are now, certainly by the end of this parliament, will be there to 40 to 50% of schools, there will be someone who does understand about these problems, who has been trained to address them. I can boast about the number of schools and colleges that are served by the teams, but I want to actually see the glass as half empty rather than half full. There will be more than half of schools that do not yet have mental health support teams in place. And I do believe that mental health support teams make a significant difference. So what are the modifiable factors for increasing school attendance? Well, these are really, really quite simple. At one level, they involve the child intervening with the student, or at least at peer level with their child, who feels they lack, they do not belong in class, they fear negative evaluations, they feel they're socially withdrawn. And these are figures that come from the National Behavioural Survey. I think it's really important for me to point out that on this survey, 41% of pupils felt that they had felt safe at school every day in that past week. So a lot of children feel that they are not safe all the time. Social withdrawal that is, again, a minority daily experience for many children. They feel that largely they're not, on most days, in the past week, enjoyed coming to school. Now, look, I didn't enjoy going to school, so that's maybe no big deal. And the fact that a large majority of them don't feel they're motivated to learn is probably not a big psychological issue. But they are worried about their classmates' reaction to their absenteeism. Parents have a responsibility, and I do want to emphasize that. Parents can do a great deal. Forcing a child to go back to school without changing anything is not going to lead to anything other than a vicious cycle of increased anxiety and increased non-attendance, leading to increased anxiety. But parents can do a great deal, first of all, by, I think, establishing cooperation with the school, understanding the child's specific concerns, and then adjusting these and in relation to the school, trying to help the school change things in the direction that the child needs. The demands on the child and expectations of the child should be modified reasonably, and that's a legal obligation of the school. Unfortunately, they experience frustration and helplessness in relation to the child's absence more commonly. They, I think, need to be helped to understand the reasons better for the child's non-attendance. And that's where I think National Health Service experiences really can kick in. I do want to emphasize, though, that what we need to change, perhaps most importantly, is how the school responds to the child, to the parents' increased understanding of the child's needs. That a school can do a great deal to change its ethos, to change the environment that promotes respect and values diversity and values, I think, something that the child needs, respect. And finding solutions to that are really sometimes very easy. So, for example, a child who feels anxious on coming to school can be made to feel good by giving special tasks and coming to school early to help tidy up the room. And that increases their self-confidence at the same time as not feeling them special. But this means making changes within the school, making the school environment predictable. And unfortunately, that's not often a general case. But I think the most important thing is to create a school environment that feels safe, calm, supportive, and inclusive for children, even if they have a range of emotional and behavioral problems that make school attendance difficult. So, in summary, what I want to say is that, as you heard from Russell, that not only do mental health problems double the risk of the child becoming persistently absent, but also doubles the risk of the child experiencing mental health at a later stage. And this creates a vicious cycle, which we really need to deal with. We do have the treatments, and we do have now the infrastructure, at least in many schools, to provide these evidence-based interventions. However, I think I have to underscore that psychological interventions are not the sole solution to these problems, but rather educational settings which are not there to diagnose, which are not there to treat, but which are there to provide the calm and safe and supportive environment that give children the confidence that they need, but do so in collaboration with parents and with other agencies. And at that stage, I shall grind to an uncomfortable halt. Thank you very much.
Oh, that was just brilliant. I think everyone would agree that it's nice to see the science behind a lot of the concepts that we've been talking about in these Agile seminars.